The last question we want to answer is how to improve immunotherapy response. And so we mentioned that most of the immunotherapy trials only work well in 20–30% of the patients, right? And it's very important to improve immunotherapy. And the key is combination therapy. For example, previously people have tried just to use anti-PD-1 or just anti-CTLA-4, but this is an example of a trial published in New England Journal of Medicine. They see that even though the single drug anti-CTLA-4 in melanoma, the response rate is only 11%. For PD-1, I think it's a little higher, probably 30%. But when you combine PD-1 with CTLA-4 together, two drugs, the response rate is 61%, much, much better. Because they work, the CTLA-4 and PD-1 are still kind of complementary mechanisms. Each make the tumor environment a little better and more activated for the T cells. This is another example of anti-PD-1 combination with chemotherapy. In the red, it's just chemotherapy alone in non-small cell lung cancer. This is survival for the progression-free survival. On the right side is the overall survival. So you can see when you only use chemotherapy, this is kind of the survival curve. But if you combine anti-PD-1 with chemotherapy, the response is much, much better. And these, by the way, for this particular trial, they required a patient to have over 50% of the cancer cells expressing PD-L1. And those are the patients that are allowed to come into the trial. And then you can see those patients really benefited from an anti-PD-1 antibody in combination with chemotherapy. And this result is even better. It's not only better than chemotherapy, later on, there are also trials to show that this is also better than anti-PD-1. Because very often the cancer cell, when it's treated with chemotherapy, will increase antigen presentation, which will then help the T cell to recognize the tumor antigen. And then with the PD-1, the T cell won't get dysfunctional. So this is a review paper from Pam Sharma, where he see that, in chemotherapy, you kind of prolong the life a little bit, but eventually patient will become resistant to the drug. In targeted therapy, you see a very good response, but also only prolong the patient. Initially, remember the BRAF inhibitor. It's like a magic cure, but only for a little bit. Eventually, the patient will develop resistance, and most of them will die from drug resistance. The nice thing about immunotherapy, even though only a minority of those patients responded, the responders, especially those that responded to CTLA-4, it seems like they can get completely cured, totally tumor-free for very, very long time. This has also been observed for some of the PD-1 patients. And the hope is that if we combine different immunotherapy, combine chemotherapy with immunotherapy, combine targeted therapy with immunotherapy, we might be able to reach a curve like this. So you can see this is the beginning of that. But maybe we can really combine them in a better way. That's when we really see precision medicine. Based on the tumor profile, we tell them, okay, you should use this targeted, this chemo, this radiation, this immunotherapy. And maybe we will get to this point. And so in order to really identify those combinations, identify also novel targets to develop new drugs, or identify existing drugs that can be combined with immunotherapy, we will need additional tumor profiles and also CRISPR screens, which we will talk about in the next lecture.